I'm going to talk about managing acute migraine. And my talk is evidence-based. So I'm not going to talk about things that have been anecdotally reported on treating headaches. So these are my disclosures. And the outline of the talk is I'm going to talk about how the treatment of migraine developed over the years or over the centuries. What are the choices currently available either for you here in Sri Lanka or the rest of the world anywhere? I mean, I'm not aware of what treatments you don't have access, but we're going to talk in general, the currently available treatment. Then I'm going to talk about what are the evidence-based acute treatment. I talk about the RCTs and the research papers published on acute treatment, which we have taken into account when we developed the BASH guidelines. I don't know how you follow the BASH guidelines, but after the NICE guidelines and European Headache Federation guidelines, BASH guidelines are also used quite widely. Then we're going to talk about an acute migraine attack. What is the best way to approach? And then at the very last, I'm going to talk about status migrainosus and what's the evidence for its best management. So let's start with the history. So it was the English physician in the late 1878 that talked about management or treatment of migraine with ergot. There is a big gap, and then Harold Wolff in the 30s and 40s in the 1900s, American neurologist, and he observed that there is a vascular dilatation in the brain and pain-sensitive structures and the cranial vessels and the meninges, which could be reversed with ergotamine. And then came the serotonin, and that was an Italian neurologist who first described the role of methotrexate as a very good preventive treatment and published the first randomized clinical trial in Lancet. Methotrexate was used widely for many, many years, and then better treatments developed, and I think Novartis discontinued it in the UK in 2013. And I don't know whether you still have it available in Sri Lanka, but we don't have it available now in the United Kingdom. So methotrexate was the main worry was the retroperitoneal fibrosis and other fibrotic lesions. So it was in the late 80s when I was trying to get into neurology that the Glaxo chap, Patrick Humphrey, further elaborated his work on serotonin and defined quite a few subtypes of serotonin receptors like 5-HT1, 2, 3, 4, 5, 6, and 7, and found out that there was a particular type of agonist acting on the serotonin receptor called, the research was the GR43175, which was later on called sumatriptan or imigran, was proved to be an excellent treatment. So the triptans really came in the early 90s and dominated the migraine world for nearly 20 years. There was nothing after triptan from 1991 right up to the arrival of Botox in 2010. So for 20 years, there was a huge gap. Triptans was a choice, but all over the years, we knew that we can't use it in people with stroke, vascular risk factors, uncontrolled hypertension, ischemic heart disease. And generally, it is recommended not to be used in people, elderly people or people above the age of 65. So the bottom graph, I'm quite happy to share the slides with the audience if they ever wanted it, shows the number needed to treat with various triptans and various other painkillers. And if you're looking at the slide like that, on the extreme left, where you see number needed to treat is 2, is a sumatriptan subcut injection 6 milligram. And on your extreme right, the number needed to treat being 11 or 12 is paracetamol 1 gram. And in between, there are many triptans, non-steroidal and simple painkillers. So what are we got currently available? These are the non-triptan medication that have got RCT evidence. They are given in alphabetical order, so it doesn't mean aspirin is any better than tolfenamic acid. The dose in the acute attack and the maximum you can use in 24 hours. We have included all of them in our BASH guidelines because they are the one who have the RCT. If you have got a non-steroidal that doesn't have an RCT, I don't think that it would not be effective because they all have a class action of all non-steroidal being good for acute migraine attack. These are the various triptans in alphabetical order, so starting from almotriptan right up to zolmitriptan. They all have got RCT evidence, and in this you can see what you use as an acute attack and the maximum in 24 hours. So in the last 2 to 3 years, there has been 2 new additions for acute treatment. One of this is ditans. Now, you know that triptan works on the 5-HT1B and 5-HT1D receptors. And therefore, the concern is that some of the BD receptors not only are present in the pain-sensitive structures in the brain or cranial, but it also shares some in the coronary area. So therefore, the main concern for 5-HT1B agonist is the contraindication to its use in ischemic heart disease and other vascular disorders. So 5-HT1F is purely in the trigeminal pathway, and they were trying to develop an agonist in the 5-HT1F, and that was the ditans, and the one which is marketed in America is called lasmiditan or lasmiditan, and all the trials that they did on lasmiditan, I don't know why they were named on wrestlers, samurai, Spartan, gladiators, but they all showed very good. Now, I would like you to focus on the therapeutic gain. Remember, the therapeutic gain of triptan is about 16 to 20%, and the lasmiditan has got a very similar therapeutic gain, and therefore it is as effective as triptan, although my colleagues in America tell me that the side effects are more than the triptans, so like dizziness or nausea type of thing are more common. So they say that although they use similar to triptan, but the side effect limits its use. Now, unfortunately, ditans are not available in the UK. I'm sure, do you have it available in Sri Lanka? You have? No. Okay. So the other one are called GPENs. Now, GPENs have been in development since early 2000. You remember, you might have heard about All-C-GPEN, Tel-C-GPEN, and many others. They were very close to marketing in 2010 when the liver toxicity stopped their marketing or further development. And then they started to work on some different forms of GPENs that were not liver toxic, and there was intensive monitoring. And now we have got 3 GPENs coming up, or have arrived. The Ubro GPEN is purely for acute treatment. The Rimegepant can be used for acute as well as preventive treatment because they are taken like as a tablet one every other day. And the Atogepant is purely used for prevention. Now, all of them are available in America. All of them, apart from Atogepant, Rime and Ubro are available in the UK on a private basis. You remember the treatment in the UK cannot be given on the National Health Service unless the NICE recommends it, and the NICE is currently going through an appraisal for Rimegepant and Atogepant. Now, if you focus on the therapeutic gain, you see that it's much less than the triptan. So I can't really see any role of these GPANs ahead of the triptans. There would be another option. So people with ischemic heart disease and having not have availability of lasmiditan, people might use Rimegepant and Ubrogepant, but the therapeutic gain is much smaller, and therefore they would be probably recommended in the UK following the therapeutic failure of triptans or contraindications to triptans. Another thing to see, if you look at the number needed to treat for the GPANs and ditans are quite high. So therefore, lasmiditan has the lowest one, and the GPANs have got higher than ditans. Okay, right. So the next one is, how does the BASH recommends based on the availability of these treatments? Now, you can treat a migraine attack when it is long before the the headache phase. So people get premonitory symptoms, then about a third of them would get an aura, then you'll get the headache, and then you'll get the prodrome. So really the acute treatment depends on which stage you would catch in. Now, many people don't really understand those premonitory symptoms. And you must be aware that now you might have heard over the years that cheese causes migraine, chocolate causes migraine, red wine causes migraine. Now they think that it is not the food that could cause migraine, but it's the craving for that food in the premonitory phase. So you're getting tiredness, fatigue, yawning, frequency of micturition, and you also have craving for certain kind of food, which basically means that you are about to get the migraine. And when you do develop migraine, you think that that's the orange juice or that's the chocolate or cheese that has caused it. There was a big study by Nicola Giffen and Peter Goolsby's group in the UK who studied all the premonitory symptoms. And long time ago, there was a randomized controlled trial that if you give domperidone, 20, 30, or 40 milligrams at the premonitory phase, when people can predict that they were the symptoms of migraine, then you can actually prevent development of the migraine attack. Now, obviously, you wouldn't know whether it's the domperidone prevented or whether they had the premonitory symptoms. And if they hadn't taken domperidone, they weren't going to develop anyway. So I think the best thing you can do is to give some antiemetics in the prodrome. There isn't a role for painkiller taking in the premonitory phase. What if you catch it at the aura phase? I know that aura takes a few minutes to develop, takes a few minutes to resolve, and all is done within an hour. Now, there is no evidence that either triptans or any painkiller taken in the aura phase would make you any better. There is some limited evidence of the IV magnesium and neuroleptics, but I don't think it is ever used anywhere in the world. But that is the only thing which has got some anecdotal reports. So I think once you have the aura, you might as well just wait for the headache to arrive. So what when you develop headache? Well, there are two approaches. One is that you start from the very basic, take paracetamol. If that doesn't work, go for non-steroidal. If that doesn't work, go for triptan. If that doesn't work, then you go for the GPANs, which are the new treatments. Or you decide from the word go what would be the best treatment in this case. So somebody who develops a single very bad headache, which would immediately produce so much disability that he had to go off work and he would have to take a day off, you might just give him sumatriptan subcut injection 6 milligram, works very quickly, and he'll be back to normal. People getting about 4 or 5 days of headache, which take a few hours to develop, you might want to try a non-steroidal or paracetamol, or give them a sort of trial of 2 or 3. And once you know which one suits them very best, you give the word go and give that treatment from the very start of it. Now, the stratified approach is better. So give the best treatment that suits the patient. Remember that if it doesn't work in 2 hours, it's not going to work. So try some alternatives. Make sure that they don't take opioids. I don't know about here, but in the UK, most of the over-the-counter painkillers available have got opiates. Cocodamol, codeine is a base in many over-the-counter painkillers. And that's a definite no-no because that pushes up the risk of the medication overuse. For triptans, we'll come about what triptan to choose, but whichever triptan you choose, try at least 3 attacks before you say it doesn't work. There are 30% who wouldn't respond. And try at least 3 different triptans before you could say that the triptans are not going to work. So which triptan would you choose? Well, it depends upon if the migraine attack develops faster and goes from mild to severe very quickly. You might want to have the shorter acting one like sumatriptan, like rizatriptan, like zolmitriptan. Okay. If it develops very gradually over a period of few hours, you might, and it lasts longer, you might want to give the long-acting one, which is the provatriptan and naratriptan. Provatriptan stays for nearly 24 hours in the system. So, subcut sumatriptan is the best. If you want people who have a longer duration, give them longer acting, which would be fro and anatriptyl. If you want a quicker response, is the Eliriza, Elmo, and Suma. And if people do have some side effects, you can choose the Elmo or anatriptyl, but they are slow to work. So if they are slow to work, you can't just wait for 6-7 hours for the triptan to work. And that is why I think combination of triptan with non-steroidal is probably the best. My choice treatment is that I give them naproxen 500 milligram, fluvotriptan 2.5 milligram. Naproxen would work within half an hour or an hour, work for about 6 to 8 hours. Fluvotriptan would kick in a few hours and would work for 24 hours. Now, there is a caveat here that if you ask the patient to take the painkiller from the very early phase when they develop the headache, because there is evidence, and that's in the bar chart on that if you take the painkiller earlier when the headache is mild, the response at 2 hours is much better. But then the problem is that if you advise the patient to take very early as they are developing headache, these painkillers, that you put them in a risk of developing medication overuse, because for every small headache, they will start to take the treatment, and obviously they are exposed to a higher risk of medication overuse or rebound headache. Okay, so that's the current evidence. Now, how would we approach? Okay, so there are 3 options that have been tested, particularly by NICE. One is that you give them non-steroidal and antiemetic, or you give them a triptan or antiemetic, or you give them all 3. So triptan, non-steroidal, and antiemetic. That's the option C. NICE thinks that this is probably the best option, and therefore this is the standard treatment for an acute attack of migraine. Remember, you have to take into account the escalation and the severity, how rapidly it develops, and how severe it gets. Okay, I'm going to talk about some of the treatments that are there. Some places it is available privately, and some places it's not. There was a trend developed in the early part of 2010, which was the gadgets. I think that was the time that iPhones came and a lot of new technology, and people started to work on the gadgets for acute attack. In 2010, this TMS, or transcranial magnetic stimulation, came as an acute treatment of migraine. I think the main study was done by the Lipton group in 2010, as when people were developing aura, they would put this gadget on the back of the head and pressed it. I usually explain to patients that this is like having a mini MRI. So this gadget emits the magnetic waves, which obviously travels through your brain, which is having an aura, and it would actually disturb the brain in a nicer way and stop the aura. Then it became very popular in the USA and UK, but none of the government authorities were very keen to fund it, because it obviously cost about £200 a month. And I think it fizzled out over the last few years, although I had about 200-300 patients on it. The 60 to 70% got better, but because of the lack of funding, we don't use it anymore. Then it was the gamma core. The gamma core device is like a vagal nerve stimulator. You put it on the right side of the neck, it buzzes and vibrates, and therefore can have an effect as an acute treatment. It has been tested in cluster, acute migraine attack, and as a preventive. But I think the results are more promising and more significant in people with cluster headache rather than in people with migraine. There was a Presto study for an acute attack, and there was an event study, so the Presto study was in the episodic acute migraine attack, and the event study, which is called here GM11, the last on the line, it showed a trend of improvement. We don't use it in the UK for migraine attacks. We use it mainly for cluster. And then these are some others. So the Cafali, the advantage of Cafali is that you buy it. You can go to Amazon and get it, £300. If it works, you can keep it. If it doesn't work, you can return it after a couple of months, and they'll give you 70% of the money back. So you have nothing major to lose if it doesn't work. The John Schumann group in Belgium and Daphne Magius was the one involved in the trial, and there is a big study called Premise published in 2013. Unfortunately, I see that the response is about 20 to 30% people get it, so a few patients get benefit, not a great deal. I have no experience with Nerivio. It's like a remote control. You wear in the arm and then it emits some stimulation. I have not used it. Relivion hasn't arrived in the UK. Is the only difference between Relivion and Kefli is that it does supraorbital or trigeminal as well as occipital nerve stimulation. We are about to start a trial on the KOS, kinetic oscillation stimulation, a company called Coordate, and the trial starting in a couple of months. You basically put a little tube in your nasal cavity, you pump it, it inflates, and it stimulates your nasal mucosa. Again, just like Botox, it was known accidentally that people in the ENT were using it for rhinitis, and it is licensed for rhinitis, or it got a CE mark for rhinitis, and they reported the headaches were a lot better. So we'll have to see what happens. And last is the status migrainosus. So it's a complication of migraine. If the attack goes on unremitting for more than 72 hours, then they are called status migrainosus. Acute attack, we know that some of the factors can actually make the migraine attack last for longer. How do you treat it? Well, this is the common approach that is developed by the Royal College of Physicians, Royal College of General Practitioner, irrespective of whether they have tried a treatment or whether they have previously tried non-steroidal or triptan. You hydrate them, you give them IV antiemetics, either the Stamatil or Maxilon or metoclopramide prochlorperazine. Then you might want to either give them oral, and if they can't tolerate it, give IV non-steroidal or IV paracetamol. And if that doesn't work, that's more economical. I mean, I would go straight for sumatriptan, but because of the cost issues, they advise that you try the IV non-steroidal or paracetamol before resorting to subcut sumatriptan. If it still doesn't work, well, you can give IV magnesium. You can give IV sodium valproate or IV chlorpromazine. If it still doesn't work, well, you can give them a greater occipital nerve block, but don't expect the nerve block to work within a few hours. It probably would take a day or two. If it says SPG on the slide, but I think we have put it on hold. I don't think we use in the UK or USA the SPG block, but that's one of the options. So the greater occipital nerve block, but I think vast majority would settle with the IV sodium valproate or magnesium sulfate. But there is something, the fourth CGRP monoclonal antibody, and I haven't talked about CGRP monoclonal antibody because it has no role in the acute migraine, but actinizumab, which the generic name is Vyepti, is just being approved by NICE in the UK. And it has got some evidence that it works for acute migraine. So when people go to ED with an acute migraine attack, you can give the actinizumab infusion. It is actually fast acting, although basically it is licensed for preventive treatment of chronic migraine, but it's an IV infusion once every 3 months and may have a role in status migrainosus. So the conclusion is that choose the best treatment from the word start. And I think what you're going to follow in your hospital, you have to develop a kind of a protocol, an agreed shared protocol between yourself, the emergency medicine, and the acute medicine, so that the patient gets the best treatment from the word go. Thank you very much.